Hey folks, welcome back to Monday Night Anatomy. This is where I share free functional anatomy lessons for you guys. So whether you're into fitness, personal training, you're a yoga teacher, Pilates instructor, you're in dance, martial arts, uh, endurance, fitness, whatever the thing is you're into, if it's movement based, then functional anatomy helps to explain what happens with the body whilst you're doing it. All right, so this is my mission to help share this information with you guys. And if you have any questions, you can always drop a question down in the comments or shoot me an email. All right. So we're going to talk today about my favorite muscle, one of my favorite muscles, the piriformis, which is this bad boy right here. Now, as always, when we're looking at functional anatomy, it helps to know landmarks. So where the muscle attaches onto the skeletal system. And there's always this kind of chicken and egg function versus structure versus function type of situation, but you can't really separate the two. It's very yin and yang. So the key thing with piriformis to kind of appreciate is that firstly, it attaches onto this green bone here, which is the sacrum. Okay. Now, the cool thing with the sacrum is that it's the primary weight-bearing bone of the spine. Okay. So all your vertebrae basically are sitting on top of this sacrum. So when the sacrum moves, the spine moves, and when the spine moves, the sacrum moves, because they're connected. And then because the sacrum sits within the ilium or the pelvis, these green bones here, ilium, okay? So when the sacrum moves, that moves the ilium, okay? And this is often referred to as the pelvic bowl. So you can kind of think like a bowl, it pulses like a bowl, okay? And so there's a whole range of muscles that control this really complex mechanism of spine, pelvis, and femur. All right, these three really massive joints that are all needed to be coordinated and synced together. And this little muscle here, the piriformis, actually plays a pretty important role because it attaches onto the sacrum actually on the front. You can see here it's got these tendon attachments onto the sacral bodies here. All right, so it's an anterior muscle. And then it attaches onto the femur, okay, on the inside of the greater trochanter here. And remember, you've also got attaching in this region, you'll have glute medius and glute minimus attaching very closely here as well. All right, so you have three big tendons that attach onto this part of the femur, the greater trochanter. So when we are visualizing muscles contract, so remember, muscles, they only pull, only when they contract, the fibers cross-bridge across each other and they kind of ratchet, and that creates a mechanical pulling action. So if the sacrum is well stabilized, which it should be typically because it's a very strong structural joint, you've got a whole range of very thick, strong ligaments that keep the sacrum nice and snug in the pelvis that we call the sacroiliac joint. So then most of the movement will have been orientated around the femur. So you can follow the line of the fibers. You can see these kind of lines here. This is the fiber direction. So when the muscles contract, they're going to pull along that line of the fibers. So the action is going to be pulling onto this head of the femur here, there, not the head of the femur, the head of the greater trochanter. Now, what can also happen, though, is that this piriformis can be a stabilizer of the sacrum in a sense, because if the femur is fixed in position, it's going to create this pulling action like this. So the best way to visualize that, if you stand on one leg, like very much like glute medius and glute minimus, which are kind of pulling the femur into the socket. Okay, they're kind of like, you have this kind of more horizontal pull, and then you got the glute medius is kind of more this oblique pull, and the glute minimus is vertical pull. So when you combine those three lines of pull, it just slides the femur into the acetabulum. So it creates a really strong stabilization. So it has a powerful stabilization role of the femur, particularly in stance, right? So if for whatever reason that the glute max and glute medius are inhibited for whatever reason, maybe there's some kind of injury or an excessive anterior tilt, which is placing the glute max in a poor position to contract. So it has what we call active insufficiency. Then this muscle here tends to take over a little bit. And when a muscle is overworked, when it's made to do the role it's not really designed to do, it can fatigue out really quickly. And when a muscle fatigues out, it means basically it runs out of metabolic ingredients to create cellular energy to create contractions. And so then it just hasn't got the metabolic fuel to keep contracting, so it fatigues. Or it's contracting and it's creating a lot of metabolic waste products, shifts the pH within the cells, and then that pH shift then actually shuts down kind of energy production in the cell. And you probably know that one more as like the lactic acid accumulation. That's part of what happens there. It's more the pH shift in the cell stops the actual energy process. Anyway, so what happens is this muscle can get overworked, it gets grumpy, it gets tired, and when muscles get overworked, they get grumpy, they get tired. They generally do one or two things. They either get inhibited, as in like they don't have a good neural feedback, or they don't have that kind of biochemical feedback, so the muscles get weak, so they can't contract. And so when the muscle gets weak, then if they don't have enough physical strength to actually do their job, then they don't do the job, all right? And so then the joints aren't getting stabilized and the joints aren't getting moved correctly. Alternatively, the muscle goes really, really tight and gets hypertonic. And from that, it creates a tension in the muscle. That tension then restricts movement again, but also then compresses other structures around it. And one of the other structures around the sciatic nerve is the sciatic nerve. So let's put that bad boy in, sciatic. See if we can get it. And as always, I'm using the Complete Anatomy app. Highly recommend you get it. And so you can see here that the sciatic nerve, this big orange one here, basically sits underneath the piriformis, and in some cases actually threads through the piriformis. So if this piriformis muscle gets too tight, it tensions and compresses down on the sciatica nerve, and that can create what we call pseudo-sciatica. So basically like this kind of radiating pain that goes down the back of your leg, which essentially follows that line of the nerve root. And it's really, really uncomfortable. Now, if that is the case, because it's a muscular compression, it's actually pretty easy to address. Responds really well to manual therapy. And depending on why, we've always got to ask the question, why this has evolved, why this piriformis has become so tight that it's compressing the sciatic nerve. Generally, it's either getting overworked because the major glute muscles aren't really doing their job. And essentially what happens is piriformis becomes a weak hip extensor. All right. Now, if I put in glute max, for example, now you're not going to find any RCT, random control studies of this stuff. This is just based on functional experience in the gym for 25 years, working in rehab, working with folks, and you just kind of put one on one together. So glute max, where are gluteus has to be gluteus. Oh, spell max right, Drew. That'll help. Got to spell the bloody word right. Glute max. Come on. Where are you? Glute maximus left. All right, so you got this powerful glute max muscle here. So this muscle can get inhibited. So usually it's by active or passive insufficiency. It's a muscle in a weak and long position. So it just can't generate enough force. And so then the piriformis, which is underneath it, has to do more work. Okay. Could also be related to if you had like a disc injury where the nerve root that's innervating the glute medius minimus or glute max is interfered with, that can create inhibition, which then can potentially weaken the glute max. So then the piriformis takes over. So the way to fix that is actually you got to retrain the entire lumbopelvic complex. And the way to fix that is you got to understand all these muscles and how they work together in a team and what their roles are. And then you layer in exercises, starting from really simple, progressively make them harder as the muscles adapt and get stronger, and then they can take more loads of full force. So to do all that, you need to actually understand what each individual muscle does. So you kind of reverse engineer it. And then once you've got that understanding of each muscle's function, and when you're laying exercise, you can kind of rebuild and restore the functions. This is why we do functional anatomy. Otherwise, you're just kind of guessing and you just kind of trying stuff out, which is an approach which can work for some folks. But my understanding is once you have a good understanding of functional anatomy, you reverse engineer it, you figure it all out, then you put it back together again, then you're looking for the patterns, all right? So if I see somebody who's got a pretty big anterior tilt, I can see that they've got atrophy glutes. So like the butt muscles are basically atrophied and they're kind of flaccid or weak, or there's not much there. When you palpate them, you can feel there's not much actual muscle underneath the butt. And then they're reporting this kind of pain is coming down here. When you palpate the piriformis into trigger points, they're usually quite active. So a trigger point is often related to a motor neuromuscular bundle. So when you compress where the neuromuscular bundle goes into the muscle, it often elicits a pain response. So that's an indicator that that neuromuscular bundle is being overworked, overdeveloped. So you release that. When you release it with manual therapy, and then it just kind of resets back, and it's basically, it's not more of a neuromuscular thing, it's more of a functional strength thing. So sometimes you can get really good, you just release the muscle with acupuncture or dry needling or a manual therapy, ART approach, active release therapy, and it restores the function. That's cool. That's more neuromuscular. But if you do that and it just kind of resets back, then the muscle's not restored to its kind of baseline strength that it needs to actually do its job. All the other muscles around it aren't doing their job, and so it just keeps getting overloaded and overworked. And that's kind of exercise rehab. We're kind of slowly building out rehab programs to help people restore function. Function is the word, okay? What the actual thing is meant to do. So the role, let's have a look at what the muscle is meant to do. So look at motion. So we've got hip abduction. Remember, these muscles work. We must be working with glute medius and glute minimus particular and glute max a little bit here. So let's fade all. There we go. So you can kind of see the orange here. This is piriformis. It's got a nice, strong, fixed sacrum here. And as it's contracting, it's pulling on the femur. And then the leg goes out to side into hip abduction. Okay. So like a side leg raise. Okay. All right, squeeze and lift. You can see here, this is glute medius here, assisting. So they're doing what we call co-contraction, working together. Of note too, here you've got one of your adductors, which is most likely sartorius. So if your adductors are super tight, they're going to counter resist the abduction here. So if the inner leg muscles are too tight, it's going to stop your leg from going out into adduction, which will then inhibit the role of your hip abductors. And so they'll get weak in that range. And because these muscles are massive, they get tighter and tighter, because the primary goal is to stabilize the femur and the knee for ambulation for gait. All right. So if you think about all movements orientated around forward ambulation or gait, all right, we want the femur to be able to rotate in the socket correctly. And we also want the kneecap facing forward so we can ambulate. So we've got to coordinate those two together. So all these muscles will basically do what they need to do to orientate the pelvis and the knee structurally in that forward vector so that you can walk forward or ambulate. And so the body will do what it needs to do to kind of create that situation. So when we're talking about postural rehab, what we're trying to do is restore this kind of alignment where all the muscles are working together. So you've got all the forces coming up and down the leg are getting distributed evenly and reduced evenly and transferred evenly. So there's no energy leaks or gaps, and there's no excessive loading going to a specific joint. And that's the importance of really learning how to move correctly. All right, spending some time learning how to kind of like anterior and posterior tilt your pelvis, activating the core, activating the pelvic floor, understanding when to engage the muscles. And this is where you need a really good coach to help you kind of go, okay, squeeze here, position this leg here. So you've got this alignment going on. So that's part of the piriformis. The other movement we had here is hip lateral rotation. This actually kind of gets confusing. So let me fade. So this is looking from behind. So what you need to do there is look at the orientation of the femur, like which way is it rotating? Okay, cool. So lateral rotation. So you can see here that the leg is turning out that way. So it's rotating out, or the trochanter is rotating externally. So this is called external rotation or lateral rotation. And it makes sense because if the piriformis is attached to the greater trochanter, and if it's slightly behind, see the line there? If it's pulling that way, it's going to rotate the femur that way. It's going to turn the shaft of the femur externally. All right. So when you're getting, if you really want to access the deep glutes, you want a little bit of external rotation and abduction, okay, as you're coming up. And usually it's around the sweet spot, generally around about 10 to 15 degrees for most folks, to get that glute med, piriformis, glute max, all working together in a really nice way. So if you can get that kind of combination together, a little bit of external rotation, a little bit of abduction, and you're going to be able to get that nice kind of hip abduction at external rotation. Now, what the tricky part is that there's a lot of individual variation on the angle of how the femur goes into the actual pelvis. So this angle here, some people, the angle is a little bit more further out the front, some people it's a bit more further out the back. So that's really individualized. So when you're teaching someone, like, for example, a deadlift or a squat, and you're setting up their stance, some people prefer a little bit external rotation. Some people prefer a little bit more of a almost parallel stance. And it takes a good eye just to make sure that when people are setting up, that they're getting good alignment of the hip joint, over the knee, over the foot. So all those kind of forces are lining up correctly, because there's going to be some very subtle individual variation. So you can kind of see here, if you drop a line, a plumb line down through the middle of the acetabular or femoral joint, the AF joint, so the hip joint, and it goes drop down here, it'll line up with the middle of the kneecap or the femoral plateau here. So this weight bearing is really, really important. So the body will orientate itself around to make this line, so all the forces are going up correctly. So if someone's got a bigger angle coming through here, all right, bigger, what we call a Q angle, that's going to facilitate different muscles to do different things. All right, so there's this individual variation that happens, and for some folks it's all good. For some people it can create some problems, but typically the body will figure it out, and if we just train the mechanics correctly, it all balances itself out in the end, which is pretty cool. All right, so the kind of pelvic mechanics can get super complicated. And if you try to, like in my experience, fix a single muscle, you kind of forget about how everything works together. It's like the body works as a system, everything's integrated together. So we need to have a systems approach. So you need to be zooming in and zooming out, zooming in, zooming out, zooming in, zooming out. So this external rotation component here, you'll never get this piriformis stronger than the glute max. All right, to look at the size of the, it's kind of like the rotator cuff on the shoulder. Small shoulder rotator cuff muscles are external rotators, like your supraspinatus. All right, similar with your piriformis, it's kind of how they mirror, hip and shoulder kind of mirror. So they're really small muscles that are kind of like creating an external rotation. When you got the big muscles like the pecs and the lats are creating internal rotation through here. Similarly, here we've got the really powerful adductor muscles. There's like 8 of them, which are all medial rotators. So they're going to try to turn the femur in. But luckily, we've got big glute max here, which will kind of like counteract. So they have a counterbalance. So the forces are even. So in a balanced system, the glute max kind of neutralizes the adductor complex. And so they're even. And so that maintains good alignment. But if you get a little bit out of whack, a bit out of balance, the adductors become too strong, that creates more internal rotation, and that lengthens and weakens the glute max, and that was where you kind of create kind of movement imbalances. And the concept there is then the forces aren't getting distributed correctly, and muscles are getting overloaded where others aren't getting much work at all. So that's kind of the key aspect of the piriformis in terms of functional anatomy. All right, it's a hip external rotator. All right, it's a hip abductor. It's a hip stabilizer. Its nerve supply is segmental, comes out of the sacrum here, so S1, 2, 3. So often the piriformis isn't affected by a lower back issue per se, because most of the lower back stuff comes out of L3, 4, 5, S1. But then what that means is that when the other glute muscles get weaker, piriformis takes over. All right. And that's where you kind of get that kind of pseudo deep glute pain, which kind of doesn't respond, kind of goes away with a little bit of treatment, then comes back really quickly. And that's where we need to restore those mechanics there. So a small muscle, but a really, really important muscle. All right. Okay, so I hope you enjoyed that. A little overview of piriformis and some pelvic mechanics. If you've got any questions, please feel free to reach out and enjoy the rest of your day.